Hello everyone. In this video, I would like to discuss the last part of the central nervous system, that is brain tumors. Before going into the topic proper, I would like to cover some important one-liner questions, that is familial tumor syndromes. The first of a kind, neurofibromatosis 1 and 2. Just the points that you have to remember. Neurofibromin 1, neurofibromin 2. That these are the genes which are mutated in neurofibromatosis. Neurofibromin 1, remember, it is mainly characterized by neurofibroma of the peripheral nerve, optic nerve glioma, Lisch nodules, and capheloid spots which are hyperpigmented macules. Whereas bilateral schwannoma, that is vestibular schwannoma, okay, is one of the characteristic feature of neurofibromatosis 2. We have another autosomal dominant condition called tuberous sclerosis complex, which is mainly characterized by ependymal, subependymal nodules, cortical tubules, okay, and hamartomatous nodules. It is mainly characterized by hypopigmented areas, that is ash leaf macules, shagreen patches, angiofibroma, subungual fibromas. It is coded by tuberous sclerosis 1 on chromosome number 9 and tuberous sclerosis 2 on chromosome number 16. Whereas in neurofibromatosis, it is chromosome number 22 and chromosome number 11. Okay. And we have von Hippel-Lindau disease, again autosomal dominant, mainly associated with the cerebellar hemangioblastoma and clear cell carcinoma of the kidney. Chromosome number is 3. Okay, 3p. That is short arm of the chromosome number 3. Fine. So this is the most important few one-liners you have to remember. And remember, in von Hippel-Lindau, it will increase the expression of VEGF, that is vascular endothelial growth factor, via HIF, that is hypoxia-inducible factor 1. So that is why you can see erythropoietin, VEGF and inhibin, all these are useful IHC markers for what say von Hippel-Lindau disease. Once this is done, let us come and see about the classification of the CNS tumors. As far as classification of the CNS tumors is concerned, okay, we have we have a classification, that is WHO classification for CNS neoplasms, and as per various criteria, that is based on its IHC markers, clinical features, histopathological features, okay, type of mutation, everything. WHO has graded the brain tumors into grade 1 to grade 4 tumors. Grade 1 to grade 4 tumors. Out of that, the first and foremost tumor that I am going to discuss, that is, we have a group of tumors called gliomas. Glioma means they are the CNS tumors which arises from the glial cells, which includes astrocytoma, oligodendroglioma, and ependymoma. That means, as the name indicates, they arise from astrocytes, oligodendrocytes, and the ependymal cells of the brain. First is astrocytoma. Remember, we have two categories here. Out of that, they are ones what we call as infiltrating astrocytoma. Whenever you hear the word infiltrating, that is grade is high, that is poor prognosis, type grade 2 to grade 4. And pilocytic astrocytoma, which is the most common type of astrocytoma, which is having a good prognosis, or a grade 1. What do you mean by infiltrating astrocytoma? Infiltrating astrocytoma means grade 2, grade 3. Grade 4 of infiltrating astrocytoma is actually called as glioblastoma multiforme, which is associated with very poor prognosis. Okay, fine. Glioblastoma multiforme. And here, what is the mutation? We have IDH1, isocitrate dehydrogenase 1 gene. Okay, we have mutant form as well as wild type form. Okay, in neoplasm, there is a new entity which has been added, that is called ongometabolism. I don't want to discuss about ongometabolism here. In against the normal substrates in Krebs cycle, because of the mutation of isocitrate dehydrogenase, what to say, there will be a formation of ongometabolite which will increases the survival of the cancer cells. Okay, fine. So here, we have something called as primary and secondary glioblastoma. Primary means early, okay, a new onset disease in older individuals, and secondary is which occurs in younger patients. Primary in older and secondary in younger patients. Okay, we have two mutation, IDH1, IDH2, wild type is also there, as well as mutant type is also there. Okay, and see, you can see in this picture, and there is also activation of CDKN2A deletion will occurs, EGFR, PDGFR gene amplification, and T53 mutations. Okay, these are the various genetic mutations we see in case of astrocytoma. Fine. So coming into the morphology, we have diffuse astrocytoma, anaplastic astrocytoma. Okay. and glioblastoma. So diffuse astrocytoma means there will be poorly defined infiltrative tumors which will distort the shape of the brain. Microscopically, you can see hyperchromatic nuclei and glial fibrillary acid fast protein will be positive. Anaplastic, they have almost the same thing, but it is more tendency towards neoplasia. And in glioblastoma, you can see in this picture, they are actually called as butterfly-shaped tumors because they will usually crosses the midline. There will be microvascular proliferation, there will be hypercellularity, there will be necrosis, okay, and there will be palisading of the cells, okay, palisading of the cells. Coming into the clinical features, as far as clinical features is concerned, okay, the mean survival, okay, is very just exceeds 5 years, and they are usually sensitive to chemotherapy as well as radiotherapy. Fine. So you can see glioblastoma, serpiginous foci of palisading cells, okay, palisading pattern along with the microvascular proliferation. They are highly vascular tumors. So this is what you have to see. And coming into the another type, that is the grade 1 type of astrocytoma, we call it as pilocytic astrocytoma. Pilocytic astrocytoma, they are distinguished that they are actually benign character. They are mainly, the mutation is mitogen activated protein kinase pathway mutation, and they mainly occurs in the region of optic nerve, spinal cord, third ventricle, and very rarely in the cerebral hemisphere. Again, they are responsive to chemotherapy as well as radiotherapy. And here we can see what to say, again almost the same cells. What is that? Hair-like process will be say Rosenthal fibers. Okay, Rosenthal fibers is one of the characteristic histopathological finding of what to say pilocytic astrocytoma. Remember, Rosenthal fibers, I have told, no, it is one of the neuronal adaptation towards injury. Okay, that means whenever there is a loss of neuron, there will be a reactive gliosis. So one such finding is actually what we call as Rosenthal fibers, which are eosinophilic granular bodies. Okay, which are a characteristic findings. So that finishes astrocytoma. When they ask about CNS tumor, first write what are CNS tumors, what are gliomas, what are the components, what are the types of tumors which comes under glioma. Astrocytoma, we have grade 1, grade 2 to 4. Grade 1 is actually called as pilocytic astrocytoma. You write what is it, MAP protein kinase pathway. Then you write about the gross as well as the histopathological findings. Then you come into 2, 3 and 4, that is infiltrating astrocytoma and glioblastoma multiforme. We have diffuse, anaplastic and glioblastomas proper. This is actually the histopathological classification of astrocytoma. Then, okay, that's it. Then coming into the next important question, that is actually called as ependymoma. Okay, what is it called as ependymoma? They are nothing else but the tumor which arises from the ependyma. Ependyma is the nothing else but the layer which actually lines the ventricle system of the brain, including that of the spinal cord. Okay, here what is the mutation? That is neurofibromin 2. I told you it is chromosome number 22. Neurofibromin 1 is chromosome number 11. That is that calls for neurofibromin protein. Whereas neurofibromatosis 2 is because of the mutation of chromosome number 22, which is because of Merlin protein. Okay, Merlin protein. And remember, they occur mainly at supratentorial, spinal as well as in the posterior fossa. Grossly, we can see they are solid masses. Okay, they are usually non-infiltrative masses. And if you see the posterior cranial fossa, they mainly arises from the floor of the fourth ventricle, which extends into the vagina. There is a foramen of Vagendi and foramen of Leschka, leading to obstruction of the CSF, leading to hydrocephalus. And remember, one of the characteristic finding in ependymoma is actually called perivascular pseudorosette. Okay, perivascular pseudorosette. This is actually the picture shown here is actually of that of pilocytic astrocytoma. Okay, fine. Okay. Then there is perivascular pseudorosette, which is one of the characteristic feature of what we call as ependymoma. We have two important histopathological variants of ependymoma, that is WHO grade 1 as well as WHO, both are WHO grade 1. There is actually called subependymoma, and next one is called mixopapillary ependymoma. Mixopapillary means which will have actually a mucin-rich fibrovascular core, and they mainly arises from the phylum terminal of the spinal cord. Okay, phylum terminal of the spinal cord, very very important. Whereas another grade 1 subependymoma, they are again slow growing nodules. Okay, and they mainly arises from the fourth ventricle. They may arise from the fourth ventricle. Again, I told you both of them will obstruct the foramen of Vagendi, foramen of Leschka, leading to obstructive hydrocephalus. Obstructive hydrocephalus is also called non-communicating hydrocephalus. Okay, fine. Fine. Once that is done, let us discuss about the final tumor, that is called as medulloblastoma. Medulloblastoma, retinoblastoma, all these are the CNS tumors which are more commonly seen in children. They are grade 4 WHO tumors. Okay, there will be obstruction of the CSF, and hydrocephalus is one of the most common clinical presentation of medulloblastoma. Here, we have a defect in the pathway called as sonic hedgehog pathway. There is an activation of WNT beta-catenin signaling pathway. Okay, that is the most important pathogenesis of medulloblastoma. And remember, on gross, we can see a well-circumscribed grey and friable mass, mainly involving the leptomeninges and the folia of the cerebellum. Okay, folia of the cerebellum. And remember, they are actually a component of what we call as a small round blue cell tumors, and hence they have what to say, very high proliferation. Ka67 is very high. Whenever Ka67 is high, it is always associated with very poor prognosis. And we have something called as Homer-Wright rosettes. They are not pseudo-rosettes. Perivascular pseudo-rosettes are a characteristic feature of ependymoma. Whereas Homer-Wright rosettes, which are true rosette. What do you mean by true rosette? There will be peripheral cells like this, and center will be empty. Okay, sorry. Yeah, center will be empty. That is actually called as a true rosettes. Okay, the true best example of sorry, I have told it wrong. Homer-Wright rosettes, they are actually pseudo rosette. Why it is called a pseudo rosette? Why? Because the center will be usually filled with something like a neuropil, we call it as. Okay, neuropil. Whereas if it is a true rosette, that is flexular Winterstein rosettes, which are true rosette, that means where the center will be empty, which is characteristically seen in retinoblastoma. Okay, and here we have two variants. One is desmoplastic variant and anaplastic variant. Desmoplastic variant means there will be desmoplasia, that is there will be increased reticulin and collagen deposition, and desmoplastia is also a feature of pancreatic adenocarcinoma. Okay, and large cell or the anaplastic variant, that is actually because of what high mitotic index will be there, hyperchromasia, okay, loss of polarity, all these features will be there. Okay, and remember a very important feature which differentiate medulloblastoma from other brain tumors is actually called as icing or drop metastasis. Okay, from the cerebellum it will drop, the metastasis will be seeding into the spinal cord via the central canal of the spinal cord. That is called a drop metastasis. And remember a very important point, what is the most common CNS tumor in an immunocompromised individual? Answer is, that is in AIDS patient, it is primary CNS lymphoma. The most common CNS neoplasm in immunosuppressed individuals like AIDS is primary CNS lymphoma. Okay, what is the most common tumor in AIDS? It is Kaposi sarcoma. Most common tumor in AIDS is Kaposi sarcoma. Most common CNS neoplasm in AIDS is primary CNS lymphoma. Okay, fine. And remember meningiomas, again meningiomas is most commonly with chromosome number 22, that is protein Merlin. Okay, Merlin. And remember the meningiomas are characteristically, histopathologically we have findings that is called Samoma bodies. What are the tumors where you can see Samoma bodies? Number 1, papillary carcinoma of thyroid. Number 2, serous hysterectomy of ovary. Next, number 3 is meningioma. Number 3 is prolactinoma. Okay, these are the 4 important tumors you have to remember where you can see Samoma bodies, which are nothing else but what a numerous, calcification. Okay, that is the calcium is deposited in the form of rings. Okay, this is called as Samoma bodies. Okay, and few paraneoplastic syndrome, which is associated with some tumors which are having some CNS manifestations as paraneoplastic syndrome, that is subacute cerebellar degeneration, which is associated with the anti-U antibody, most commonly seen in ovarian, uterine or breast cancer. Next is limbic encephalitis, which is characteristic by subacute dementia, okay, which is associated with anti-U antibodies, and this is actually another paraneoplastic syndrome, most commonly associated with small cell carcinoma. Whenever you remember small cell carcinoma of the lung, you have to remember SAADH, Cushing syndrome. Next is limbic encephalitis. Okay, fine. And myoclonus, opsoclonus myoclonus syndrome, which is actually another important paraneoplastic syndrome associated with a neuroblastoma. Lambert-Eaton myasthenic syndrome, again, which is another paraneoplastic syndrome which is associated with small cell carcinoma of the lung. Okay, so with this we have finished almost all the tumors, and I think this is more than enough for you to answer both the MCQs, your Viva, as well as for your theory exams. Thank you.